Hey all my beautiful dental squad, welcome back to our Mission MDS 2024 Recall and Revise series. So in this revision video, we are going to see about mucosal lesions. Here we are going to importantly discuss about three types of mucosal lesions that are lichen planus, leukoplakia and pemphigus. Okay, so let's just dive into these and revise it rapidly. Right, pemphigus. So pemphigus, as you know, it is a autoimmune disorder, right? So it is an autoimmune disorder which blistering, okay? Skin blisters and mucous membrane blisters are seen in pemphigus. So diagnosis is through intraoral erosions or ulcerations might be seen with a history of blister formation. So in some cases, there is positive Nikolsky's kind. More positive Nikolsky's kind is when the upper layer of the epidermis is rubbed off, there will be erythema. So that is Nikolsky sign. Then biopsy findings. What will be the biopsy findings? Intraepithelial blistering and immunofluorescence studies demonstrate intercellular antibodies, that is IgG, along the epidermal cell surfaces. The management of pemphigus is, as it is an autoimmune disorder, we'll go for systemic corticosteroids, which is as the first line of therapy to suppress the autoimmune response. Then other immunosuppressive agents which we use are azathioprine, mycophenolate mofetil, or rituximab. Okay, so supportive care to manage skin and mucosal lesions is important. That is, we give topical corticosteroid creams. So here you can see the presentation, how it will be on skin, right? Blister lesions are seen. And in histopathology, there is a blister formation, right? And coming to oral lesions, you can see how far it is spreading, right? And you can see the positive, what is this? Nikolsky sign, right? Then, so these are the important points around pemphigus. So let's see a question. So which of the following conditions is characterized by autoimmune intraepithelial blistering and can present with oral mucosal involvement? It is pemphigus, right? So based on the provided clinical image showing intraoral mucosal erosions, what is the most likely diagnosis of this patient? So see, here you can see erythematous lesions that are appearing in the mucosa here. So the options they gave were pemphigus vulgaris, erythema multiforme, aphthostomatitis, and oral candidiasis. So the lesion, how it will appear, you have to keep in mind. Pemphigus, there will be blister association, okay? And recurrent after stomatitis, how it will be? It will be like an ulcer, right? And one more, what they have given, oral candidiasis. There are white patches is seen. The other, the one more is erythema multiforme. Erythema multiforme, it will not be seen like a blister formation. Okay, it is seen as a flat lesion. Okay, so these are the main important signs you can remember with these uh, diseases. Okay, so with this in mind, you can come to an answer that it is pemphigus vulgaris. Okay, so you have to remember the clinical pictures, how the lesions are. It is not only for these, it's important for every other disease that you see. Okay. Then coming to leukoplakia, our favorite one. Leukoplakia refers to white. Erythroplakia, red. So that develop on the mucous membranes of the oral cavity. So leukoplakia, white patches, which cannot be rubbed off. Okay, this is important. The question will be like this. White patches in the oral mucosa, which cannot be rubbed off. Then you have to go for leukoplakia and is associated with increased risk of dysplasia or malignancy. So these lesions appear anywhere in the oral cavity, but commonly found in buccal mucosa, tongue, floor of mouth, and lower lip. They may present as homogeneous or non-homogeneous or in association with erythroplakia, right? So the white patches may be smooth, nodular, or corrugated. Okay. Biopsy may be performed to rule out the malignancy condition if present or not present. Management is depending upon the causative character. So what is the causative character? We have to avoid that. Especially we'll have tobacco usage or alcohol usage or chronic irritation from dentures or chronic irritation from any other uh, opposing tooth can also lead to leukoplakia. So regular follow-up and proper care is required for leukoplakia. So you can see the white patches. So these are the white patches we can see in leukoplakia. So the signs and symptoms are loose teeth can be seen, red and white patches, tongue pain, and mouth sores. Okay, so these are the important signs and symptoms around leukoplakia, right? So one more thing, the differentiation between the white patches we see in oral candidiasis and that we see in leukoplakia. So oral candidiasis, the white patch gets rubbed off easily and underlying erythema can be seen. Whereas in leukoplakia, the white lesion cannot be rubbed off. The malignant potential is very much in leukoplakia. So hence biopsy should be performed. Whereas oral candidiasis can be treated with antifungals. So here is the histopathology image of leukoplakia where we can see hyperkeratosis, right? You can see how much it is like. So this is the main histopathological finding in leukoplakia. Okay, then coming to a question. A white lesion on the oral mucosa that cannot be rubbed off and is associated with an increased risk of dysplasia or malignancy is most likely. That cannot be rubbed off is lichen planus, pemphigus. No, it is leukoplakia, right? Then so here is one more lesion. So most oftenly when they give leukoplakia, they give lesion on tongue because this is the most prevalent area. Okay, so examine the provided clinical image showing a white lesion on the lateral border of the tongue. What is the most appropriate next step in managing this patient? So since the patient, we can arrive to this think like it is a leukoplastic lesion. So what will be the next step in managing? Initiate topical corticosteroid therapy, perform a biopsy, prescribe antifungal medication, or refer the patient to an orthodontist for evaluation. So first of all, we have to do a biopsy. Okay, whenever you find a white suspicious patch in oral mucosa, red suspicious patch in oral mucosa, any suspicious patch in any color, first point you have to go to biopsy. Okay, then only we can arrive to the diagnosis proper and then continue the rest of the management of the lesion. Okay, then coming to lichen planus. So lichen planus, which is a chronic inflammatory condition that affects the skin, mucous membrane, hair, nails, and it presents as pruritic, polygonal, flat-topped, violaceous papules or plaques. Okay, so this is very, very, very important. Okay, so why I'm saying it very important is you have to know, you have to remember how the lesion looks in every disease. Okay, every disease you either have plaque, you either have papule, you either have macule, you either have a white patch. So you have to be very like you have to remember this distinguishing point. Okay, like what is the distinguishing point that we can do in this disease? So this is the very important thing. You either make a table, you either make a chart where you can just list out these distinguishing characteristics so that you can keep on revising so that you don't forget it. Okay, so in lichen planus, it will be violaceous papule or plaques. So this is very important. So clinical features, as we have seen, papules or plaques that may coalesce to form larger lesions, and oral cavity commonly affects buccal mucosa, tongue, gingiva, presenting as white striations. White striations are seen in lichen planus, erosions or ulcers or plaques. So these white striations appear as fine white lacy lines which are called as Wickham striae. This is very, very, very important. Lichen planus, you have to remember two main important things. Become striae, sawtooth retiratus. So these are the points they'll ask in normal your uh, what we say viva, your university exams, and also in NEET MDS. So this is very important. Okay. But lichen planus is a condition that is chronic inflammatory condition. Okay. You remember that. Don't confuse it with autoimmune disorders. Okay. So histopathological reveals band-like lymphocytic infiltrate with at the interface between epithelium and connective tissue, which is seen as sawtooth retiratus. Sawtooth retiratus. So these are very important points around lichen planus. So we can see how it is like skin lesion, plaques, violaceous plaques, pruritic plaques, oral lesions, Wickham's striae. You can see white patches with Wickham's striae. Okay. Management will be topical corticosteroids and systemic corticosteroids or other immunosuppressive agents, and regular monitoring of the patient is required. Okay. Then coming to a few questions. So let's just see an question here, right? Which of the following condition presents with pruritic, polygonal, flat-topped violaceous papules and plaques involving skin, mucous membrane, hair, and nails? So I told you violaceous papules, plaques means it is lichen planus. Okay. Then coming to the image here, it is showing Wickham's striae. So provided clinical image displaying reticular white striations. He already gave a clue in the question. Reticular white striations, which is most likely diagnosis, it is lichen planus. Oral candidiasis occurs as a white mucus patch. Fordyce granule, white, small, pinpoint lesions. Geographic tongue, red and white patches all over the tongue, right? So these are the important features you have to know. So if you like our video, do share to your peers. Do let them also revise. Okay. So do please subscribe and keep following. So let's just revise it as quickly as possible. Thank you.